Back to Basics. Understanding Decompression Illness by Nicholas Bird. Decompression illness is a fascinating condition. It lurks in the shadows of divers' minds, and it reminds us that we are vulnerable and that our push to explore is tempered by potential consequences. Whether ascending from depth or traveling to high altitudes, as we move outwards and upwards from the Earth's center, the ambient pressure decreases. Under the right circumstances, this can initiate a complex interplay between physics and physiology that can lead to injury. Divers face two types of decompression-related injuries: decompression sickness, that is DCS, and arterial gas embolism, or AGE. Collectively, these conditions are often lumped together and are referred to as decompression illness, or DCI. Their common origin is the process of decompression, but their underlying causes differ significantly. In the case of AGE, the disabling injury in 29% of dive fatalities is likely associated with insufficient gas supply, which is the trigger in about 41% of diving accidents. Emboli as such are actual or potential blockages of blood vessels by any foreign material. This can be composed of gas, blood clots, fat, tumors, amniotic fluid, or bacterial clumps. In the case of AGE in divers, the emboli are made up of gas in the arterial bloodstream, resulting from the lung overexpansion or pulmonary barotrauma injury. This means a physical injury to lung tissue as a result from expanding in response to pressure changes. These injuries allow gas to escape from the small air sacs of the lungs or alveoli and enter the arterial bloodstream. Boyle's law applies here. The law states, the volume of a quantity of gas will increase as ambient pressure decreases. That is what explains lung overexpansion on ascent. The reverse of this law is also true though. The volume of a quantity of gas will decrease as ambient pressure increases, such as happens with descent. Divers face the highest risk of pulmonary barotrauma in shallow water. The greatest pressure differential experienced by divers in the water column, that is, relative to the ambient pressure at the surface, occurs in the first 3 to 5 meters. Expansion of gas beyond the point that the alveoli can accommodate it results in lung tissue damage, and that enables air trapped in the lungs to escape into the pulmonary veins. Expansion of gas beyond the point that the alveoli can accommodate it results in lung tissue damage, and this enables air trapped in the lungs to escape into the pulmonary veins, which return oxygenated blood to the heart. So when this happens, the escaped air directly enters the heart and may move to the brain, where it can cause an acute neurological injury. The speed with which this happens explains the rapid onset of symptoms following a dive. AGE can occur within seconds or minutes, sometimes even before surfacing. Pulmonary barotrauma can manifest as free air in the mediastinum, which is an area in the chest between the lungs, which is then called pneumomediastinum. Or it may manifest as a pneumothorax, that is air in the chest cavity outside the lungs. The greatest threat to divers, though, is AGE, which reaches the brain, a condition then known as cerebral arterial gas embolism, or CAGE, CAGE. Symptoms of CAGE manifest at or near the surface immediately after a dive, and approximately 50% of divers who suffer CAGE experience sudden loss of consciousness. Others may have acutely altered mental status or loss of coordination or strength, which are all signs or symptoms similar to stroke and are the result of restricted blood flow to parts of the brain. Those who survive the initial injury may spontaneously revive within a couple of minutes, showing varying degrees of stable or persistent neurological injury, even as function returns to more normal states. Regardless of how complete the recovery seems, all victims of pulmonary barotrauma, AGE, or CAGE should be evaluated urgently in a hospital emergency department. Neurological symptom recurrence is known to happen in patients, even those with apparent full recoveries. The consensus amongst hyperbaric physicians is that anyone who shows signs of neurological injury after a dive should be evaluated. People diagnosed with AGE should receive hyperbaric oxygen or chamber treatment. CT of the head are sometimes part of these patients' initial evaluation when they reach the emergency department. This is sometimes important to assess the nature of the brain lesion and to determine whether it's due to a stroke or a bubble before initiating chamber treatment. This is not so much because hyperbaric treatment will worsen the condition, but because bleeding in the brain requires or may require immediate surgical intervention. So ruling out intracranial bleeds and blood clots that do require acute neurological surgery or other interventions need to be distinguished from bubble-related problems that are treated with hyperbaric oxygen. DCS, bubble trouble. DCS is associated with the absorption of inert gas, which might be nitrogen or helium, into tissue coupled with an ascent to reduced ambient pressure, where the elimination of the gas may result in bubble formation. This promotes inflammation or tissue trauma. As part of our understanding, the gas laws of Boyle, Henry, and Dalton all apply here. Boyle's law explains why we must inhale progressively greater numbers of gas molecules per breath as we descend, in order for our bodies to maintain pressure and our chest to remain equal as the ambient pressure increases. The increased number of gas molecules in our lungs relative to those in our blood and tissues creates a diffusion gradient. According to Henry's law, that drives the gas molecules into solution. Which and how many of these molecules we absorb is defined by Dalton's law and is also influenced by differences in blood flow to different parts of our body. The longer and deeper we dive, the more gas we absorb. When sufficient quantities of inert gas come out of solution and form bubbles during ascent, local and systemic inflammation and vascular reactions may ensue. These can potentially lead to a broad range of clinical manifestations. Unlike AGE, DCS bubbles exist primarily in the venous bloodstream and within tissues, so the symptoms may not appear for several hours. DCS is linked to an inert gas load or decompression stress and the presence of bubbles in bloodstream. Although high bubble scores, such as might be evaluated with Doppler ultrasound, are not diagnostic of decompression sickness, they do indicate considerable decompression stress and are therefore more likely to be associated with the onset of DCS symptoms than lower scores would be. Symptom onset time is roughly correlated with the inert gas load. In other words, higher loads are more likely to represent quicker onset of more severe symptoms. A fascinating aspect of DCS is that symptom onset often occurs well after bubbles are detectable. Thus, while bubble detection is an indicator of decompression stress, it is not a diagnostic criterion. Current research in decompression sickness is focused on biological markers that can be detected in the blood. Investigators are exploring the potential association between decompression stress and the presence of membrane microparticles, that is, membrane-bound vesicles shed from a variety of cell types in the blood. Microparticle levels may increase in association with a number of physiological disease states, as well as with the shearing stress caused by bubbles in the blood. The working hypothesis is that certain microparticles, possibly induced by inert gas bubbles, may initiate and be a marker or otherwise contribute to the inflammatory response that leads to decompression sickness. This investigation goes beyond the pure bubble model. While bubbles in the blood certainly play a key role in the development of decompression sickness, their presence or absence does not reliably predict decompression sickness symptom onset. Investigating this process at the molecular level may teach us a great deal more about decompression sickness, providing insights that we hope will improve the effectiveness of both prevention and treatment. Fortunately, DCS occurs rather infrequently. Based on data Dan gathered during Project Dive exploration, the overall incidence of DCS is 2 to 4 cases per 10,000 dives. The incidence rate drops to between 0 to 2 cases per 10,000 dives from warm water resorts and liverboards, and it rises to 10 to 12 cases per 10,000 dives in samples of populations of deep technical divers, especially those in northern Scotland. Treatment for either DCS or AGE involves the use of hyperbaric oxygen. Prior to this definitive care, breathing 100% oxygen can expedite inert gas washout, reduce symptom severity, and enhance treatment effectiveness. The most common accepted initial chamber treatment protocol is that of US Navy Treatment Table 6 or Royal Navy Treatment Table 62. Depending on patient status, these treatments may be extended or repeated. DCI is treated with equal effectiveness in both mono and multi-place chambers. Monoplace chambers treat one person at a time, and the patient is unaccompanied by medical staff inside the chamber, although medical staff attend to the patient throughout their treatment. Multiplace chambers enable simultaneous treatment of multiple patients, and medical staff can accompany the patient, which is particularly important for more seriously injured people. Evacuation. Dive accidents can be frightening. Many divers fail to consider alternative explanations for the symptoms. To ensure that other severe injuries, illnesses, or conditions are considered, Dan recommends that injured divers seek medical evaluation at the nearest hospital or medical clinic. If DCI is indeed the diagnosis, the staff and, if necessary, Dan can initiate a timely transfer to an appropriate and available hyperbaric facility. Dive accidents prompt many questions. After you've contacted local emergency medical services, consider contacting your local Divers Alert Network hotline and encourage the treating facility to do the same. Dan can provide pertinent medical information as well as assisting with the planning and coordination of an evacuation.